Hi, everyone. It's a big pleasure for me to share today with you my experience with MTA and aligners, and in particular, how to use a mini tube appliance in combination with aligners to overcome the aligners limitation. First of all, let me introduce myself briefly. My name is Alessandro Mario Greco. I'm an Italian orthodontist. I live and work in Rome. I'm a member of many societies, and in particular, I decided from at least 15 years to work exclusively with aligners. So my office in Rome nowadays is almost 100% dedicated to the aligners. I live and work in the most beautiful city of the world, which is Rome, and I can easily manage, let's say, the way in which I'm working by uh, applying my concept. And my concept is using aligners for almost 100% of my cases. Why I do this? Because I love digital, first of all. I love the idea of working in a different way by collecting all the information and using all the beautiful technology that we have today in order to see definitely how will be my orthodontic treatment. But of course, I'm pretty aware that all this beautiful technology is nothing if we don't think what we are doing. So there should be a mind behind all this beautiful technology. And this is why, because we know that working with aligners, we can have some limitation. And this limitation can be resumed in two big problems. So first of all, extrusion control. So what aligners cannot do 100% can represent a problem when working with aligners. Extrusion control or root control. Definitely, when we talk about extrusion, we have a problem related to our troubleshooting process. So what does it mean? We plan extrusion, we don't see extrusion, we need to find a troubleshooting. When in case we have retained canines or impacted canines, how can you manage to do a big extrusion only with aligners? So the use of auxiliaries, in particular mini tubes, this can be amazing in this kind of problems in this extrusion part. But there is also a beautiful, amazing application of MTA when we talk about root control. And I'm going to try to give you a flavor of these both problems, extrusion and root control, in the time at my disposal today. So let's start with the first step, the first pillar, extrusion, definitely. So we know normally what happens. So sometimes we can have some poor tracking. What does it mean? We plan extrusion, or we sometimes happens that we don't do all the planned IPR. That means that sometimes we see this one. Like in this case, I was treating these patients for crowding with aligners. There was a lot of IPR planned. I was not able to do all the IPR. So the aligner was pushing in absence of space, and this is what happened. We see a problem of tracking. In the same situation, instead, we have sometimes in particular, pretty commonly with lateral incisor, we plan extrusion, we don't see extrusion, or because of the use of a specific tool, which is the power reach, we plan torque, we don't see torque, but we see an undesired intrusion. So in both these situations, we have a tracking issue. How can we manage a tracking issue? Well, what we learned until now is this one, using what we can call leading elastics. That means removing all the attachments, placing a buccal button, placing a lingual button, and then asking more cooperation to the patients. Remember, we are asking for a compliance of 22 hours per day. And now we are also requesting more cooperation by using elastics for 22 hours per day. We need to do more IPR. and using short, heavy elastics. So the cooperation we ask from the patients is increasing in this kind of situation. And then we can reach, let's say, success. But honestly, since I'm really asking a lot of compliance to my patient, because 22 hours is a huge time, sometimes if I can, I will try to remove this. So I will definitely try to minimize the cooperation in using elastics unless I do really need elastics, like in situation like this one that you see now when we have really high canine. How can we overcome this? Well, this is a big limitation. And generally, what I'm doing is connecting and integrating MTA in alignments. We know very well MTA by Osstem. They are different kind of shape. I normally use the semi-rounded. They have an extension of 3 millimeters with this beautiful silver slot of 0.18. And as you can see, they perfectly fit the cutout of the alignment. This is amazing because in a situation like this one, in which I have a loss of tracking, a tracking issue, what I can do is using 2 or 3 MTA. In this case, you see a couple of MTA, and for aesthetic reason, bonded, directly bond on the central incisor to recover the position. I'm using the 012 thermal night eye thermal wire in order to control the extrusion. And the only thing I need to think is that, of course, in 1 month, I will see the, let's say, the wire going out of the distal TMA. You see here, how can we easily recover? That means that I don't really need to scan again. I can simply combine this auxiliary easily in my orthodontic treatment with aligners. This is what happened, for example, in the same way when I want to extrude, because I have a really high canine like this one. Nowadays, I don't ask for cooperation with elastics anymore. If I know that my patient will not be compliant, and if I don't want to stress my patient, I can easily work with 3 mini tubes and see a really nice extrusion following my plan. You don't see attachment in this picture because I'm using attachments from the lingual surface. And that's the reason why I can control the extrusion movement, both with aligners, because it's blend into the aligner, both with MTA, avoiding completely the use and the cooperation with elastics. In this case, I'm using a straight segment of 0.14 night eye wire. This can be an alternative option from what we said before. And you see that the extrusion is absolutely coming, is performing pretty nicely. Even though we see a reaction in the premolars, we know as soon as we remove everything, the plastic in particular, there will be a normal settling of the occlusion in this kind of situation. But of course, if you have a really high demand aesthetic patient, the same troubleshooting situation can be, for example, done from the lingual surface. And as you can see, we can extrude the lateral incisor, recovering the tracking issue by using the same system in only 5 weeks, because the big advantage of using MTA is that we work in a really low friction condition because of the tubes are covered, are metal covered by silver. So that means that the friction is pretty low. And this is a super big advantage because in 5 weeks, with a system like this one, 012, again, thermal wire for the anterior part of the arch, no MTA on the lateral incisor, but a direct bonding connection, and we see an extrusion coming. So we can easily recover a situation like this one. But let me give you another more specific example on troubleshooting that can be really interesting. Look at this patient. This is a patient that came to me, of course, for crowding, for deep bite. I was doing my plan, and as you can see in my plan, what I did is proclination of the incisor, because this was really good for her profile, of course. So I was trying to do this, but as you can notice, probably the lateral incisor is retracting because it was really too much vestibular, too much proclined. There was some attachment, but as I told you, I'm using lingual attachment, and sometimes when an attachment is failing, what happens is that you can go in a tracking, you can find yourself in a tracking problem. This is the situation. But the tracking problem was not limited to the lateral, in this case, also to the central incisor. This is a big problem because my option now is July 2024. I should asking for a new scan probably, and then trying to do something. Or I have an alternative option. My alternative option was this one, doing a sort of overall half arch bonding by using MTA. And the MTA I'm placing, as you can see, I'm definitely following the extrusion, the forced extrusion of lateral and central incisor. As you can see, this is the way in which I was placing them. And then, of course, I was using the same 012 night-eye thermal wire. Then I see the patient again in August, and look at what happened. No more problem on the lateral incisor. Perfect. So what I can do now is replacing the button on the tubes on the central incisor using the same wire, no change. And in September, as you can see, there are no more problems of tracking. I'm still inside the same set of aligners. I'm not changing. I'm not asking for additional. But as you notice now, the tracking, the fitting of the aligners is pretty nice. Thanks to my auxiliary, thanks to the use of MTA in combination with aligners. Something that is pretty interesting, sometimes we forget about this, is that MTA has got no bondable surface. That means that when you want to replace from one position to another, you can simply break the composite, remove the composite from the tubes, and then replacing, rebonding in a different position. This is pretty interesting in my opinion, because we can do a lot of things. But this is, let's say, the most easiest connection between MTA and aligners. Let's try to understand what we can do in situations that can be slightly more complex. Let me show you a situation of a retained canine, for example. In a situation of retained canine like this one, you see we have a class 1 on the left side, class 2 on the right side, no space for the canine. The canine is not really impacted because it's in its position, it's just retained. So we know that we have also class 3. We know in this kind of situation that generally when we define the space opening with aligners, like in this case, in only 18 aligners, once that we open easily the space, the canine should easily erupt spontaneously, let's say, if we have the patience to wait some time. But of course, one of the complaint of this kind of patients, the parents of this kind of patients, most commonly, is always asking when the canine will come. So definitely what we can do to, let's say, speed up the treatment, we can easily open the space with aligners. You see the amount of space we can open in 18 aligners. It's pretty fine. At this point, what we can do easily is planning a phase in which we are going to use a laser gingivectomy to open, as we can see here, the canine, and starting using our system. Let me explain a little bit more in depth what I'm doing here. Laser gingivectomy, I placed a button on the canine and I was using mini tube appliance on 5 and 4 on the premolar. I was using a 0.16 stainless steel Australian wire cantilever in order to move the canine in a forced eruption condition. As soon as canine is coming, as you can see here, there was a slightly excess of gingiva. Look at the reaction, which is pretty big. So I was extruding the canine, and then you see a partial extrusion of premolars. I'm not really worried at this point. What I'm doing is using another couple of MTA, one tubes on the canine, one tubes on the lateral. I'm using a 014 night eye wire, so I'm using a different kind of wire, and look at what happened. Relapse of the intrusion, now we have contact. Canine is derotating. At this point, as I told you before, what I'm doing, I'm using the same piece of night eye 014 wire to do what? To debond from this position. So what I'm doing is debonding the MTA from here and using the same MTA, the same one in a different position. So I found this one of the best feature of this auxiliary. So using the same, because we don't have any kind of bondable surface, so we can easily use the same. Look at the position of the canine. It's fully wrapped. Of course, the occlusion is not perfect. So at this point, I can scan again. I can remove the MTA and I can dedicate the second part of my treatment to refine the position of the canine and refining the occlusion. So mesializing, so we have a class 3. So something absolutely super efficient, I will say. One set of aligners, 18, MTA, and then a second set of aligners, 27, to achieve a nice intracuspation and a nice occlusion. You see here during the treatment and then at the end of the treatment when you can see a more precise intracuspation. So this is something that I really found amazing, honestly, because it's a kind of situation which is absolutely not easy to manage only with aligners. Sometimes someone is doing, and that means that someone is asking the patients to use a lot of elastics, like in combination, let's say, with aligners. But how can we just leave the success of a retained canine to the patient's use of elastics? That will mean probably leaving to them the success. And sometimes it works, but sometimes it's not. And however, we can be really stressful in terms of cooperation. So that's the reason why, honestly, I prefer to use this auxiliary. Of course, retained canines doesn't mean impacted. When I'm treating impacted canines, the situation starts to be slightly more complicated, as we said before. And of course, again, impacted canines, how can we manage only with aligners? Honestly, I prefer to use some TATs, and that's the reason why, in cooperation with another Italian orthodontist, my friend Nicola, we realized and we published it on APOS journal, APOS Trending Orthodontics, our protocol, which is called TAT Smart Easy Bending. And what we are doing, we use two TATs in combination with sectional wires without touching the teeth. Something like this. This is a way for us, in particular for me, reopening the space with the aligners and then using two mini screws to achieve the success. This is pretty common, but of course, pay attention. Imagine a situation like this one. I can follow my approach. I can recover the position of the canine after I open the space for the impacted canines, because we know that impacted canines can be more difficult than retained. And so we need for sure TATs, and we cannot leave to the elastic use the success of what we are doing. So for this reason, in this kind of protocol, what I'm doing is selecting the proper auxiliaries. And the first step can be this one, using one single TAT. These canine are more in a buccal impaction. So I'm using a screw to move the canine in a more buccal direction with a mini screws and one sectional. And once I see the canine, I don't waste my time asking to use elastics. I'm using immediately mini tube appliance with a 014 night eye wire. And you see how this, in few weeks, can be super, super efficient, because you see that definitely in a few weeks, in a few months, we see that canine is fully erupting, forced by the use of mini tube appliance. So this is something pretty good, in my opinion, that we can absolutely manage with this kind of situation. And it's pretty useful, because remember that that will be really difficult. So definitely when we have an impaction, what we can definitely do is selecting to approach in different stages. One stage is reopening the space. That means using aligners to do this. They can do in a really nice, fluent, without any problems, in a fluent way. Once that we can be able to reopen the space, in this case also to fix the crossbite, then we can use our system that should not always be only on the buccal. We can do the same in the lingual, so we can be more, let's say, aesthetic for our patient, what we are doing. And once the canine arrive almost in a spinal position, why we should wait or asking patients to use elastics? Again, our goal, once we see the canine, we can try, for example, in this case, to combine again aligners, as you can see here. But when you look at the table of the movement and you realize that this is a small movement for the crown, but a big movement for the root, so it's not only extrusion, but is a huge root movement, at this point, the best thing that we can do is trying to combine our MTA auxiliary system, because it's the only way to move in a more predictable way this kind of situation. You see here, once again, sometimes when it's not enough, I'm doing a rebonding of the same mini tube, and then I can achieve finally my final position and my extrusion. You see again, I'm doing pretty commonly, not only once. Sometimes when I see that I still need to upright the roots, I'm changing, or I need more extrusion, I'm changing the position of one or two mini tubes. So in this way, I can easily manage to finish in the proper way, like in this kind of situation. So I would say that 100% in an extrusion control, these auxiliaries can be fundamental. Honestly, nowadays, I don't work without anymore. And this is why, because it's pretty useful. And I don't use brackets. Why? Because I need ligatures, or at least they are really bulky, so they are really not pleasant in combination with aligners. Nowadays, I don't buy brackets anymore. I'm only using aligners, and in a situation like this one, extrusion, I always have a large amount of mini tube appliance ready to be used. But even more interesting, I think, when we have a situation of root control, this is an auxiliaries we need to manage, we need to have, we need to use in combination. Let me give you an example, for example, of tipping control. This is an adult patient I treated some years ago. And as you can see, there is a midline shift, but nothing else. Is a nice class 1, is a nice woman. The problem is that there is one missing lateral incisor. And as you can see, we have canine in the position of the lateral incisor, a class 2 on the left, a class 1 on the right. So how can we manage to reopen the space? Because this patient was sent to me by the general dentist, by the implantologist, asking me to reopen the space to place an implant. Well, this is something really not easy, let's say, to do. And this is why, because of course, that means that I should need to use probably some auxiliaries. Look at the space between the roots. It's nothing, the space between the roots. I know I can manage the position of the canine. I know I can easily manage the midline, but as you can see, in order to reopen the space, the root proximity is pretty close. So we need to completely reopen the space. This is the huge problem. However, if I'm looking at my personal parameters when dealing with a genesis, age is telling me open, aesthetics is telling me open, occlusion is telling me opening because we have a class 2 on the left. I need to open, nothing to say. But pay attention. I know from the beginning that the canine distalization present a favorable condition because the apex of the canine is more distal than the crown. But look at this. The inclination of the central incisor is not favorable to be moved on the mesial direction. This is a problem. This is a problem. So I know perfectly that I can do my plan. I can try to do my best, let's say, using attachments, distalizing, doing IPR, correcting the midline, and trying to over-correct the midline. Look at this, trying to over-correct the midline. This is what I'm doing, and I'm doing 2 millimeter of mesialization of the 2.1, this tooth here. But when you look at the crown, only 2 millimeters. Try to change on the table of the movement and look at the roots. Whoa, so the roots is not moving only 2 millimeters. The root is moving almost 5 millimeters. And with aligners, this will be something really complex. We can try to over-engineer in the digital, but this is not easy at all because it's really complex management, moving only the apex of the central incisor 4.6 millimeter in a more mesial direction. So it's pretty complex. It's pretty complex. I tried to manage in 27 aligners, as you see here, but I know from the beginning, the initial inclination, axial inclination of the incisor of the 2.1 is not favorable. I try to over-engineer, that means over-correcting in the digital, but I know even, you see the over-correction means that I finish with over-tipping, but I know this will never be so easy, never be so easy because the root is moving for almost 5 millimeters. And as I knew from the beginning, this is what happened. Look at this. An excessive tipping of the central incisor. This is a big mistake. How can I manage this? You see the roots seems to be even more closer than at the beginning because of this movement. Let me immediately cut the lingual surface, the palatal surface of the aligners and place some MTA properly placed. What does it mean properly placed? Of course, I need some extra aligners, so I do an additional, but properly cut means properly placed means this one. I'm trying to follow the long axis of the central incisor. You see here, 1, 2, 3 MTA. If you try to take a look to this one is almost straight. This one has been angulated in the proper way to control perfectly the root movement and the uprighting of the roots we need in this kind of situation if you want to achieve the proper space opening. This is beautiful, in my opinion. This is a 0.12 thermal wire. I can then move to a 0.14 wire, and this is what happened. You see now we have almost reopened the space. We have a class 1 occlusion, and now we can finish our treatment, send the patient to the prosthodontist that will place the implant in a really, really super small space. And then finally, as you can see, he will place all the other implants in this mouth. So we can finally found a really nice rehabilitation of these problems of this malocclusion in this kind of patient. So this is almost beautiful, but look, without MTA, I was lost in this kind of situation. After MTA, I can see a pretty nice working. Of course, let me explain you. I work with MTA in combination with aligners. That means that aligners will do the same kind of movement MTA will provide. This is fundamental. You see the difference here between before and after. So it was absolutely not easy to reopen the space in this kind of situation, but I was able to get my success of treatment thanks to the use of something that, in my opinion, nowadays is fundamental. If you want really, like me, to use 100%, let's say almost 100% aligners, that means that we need, in some particular situation like this one, to have many tubes with us, because unless some particular movements can be really, really super difficult to achieve. This is one example of root, let's say, control, but we have many examples. Again, when we have a genesis, we know that this can be a problem. In adult patients, we can reopen. In young patients, in teenager, at least in Italy, one common tendency is to close the gap by visualizing everything when we have a genesis. In this particular patients, I have one agenesis of only one lateral incisor, the left one, but we have the right one. So the space closure in an asymmetrical way can be really complex. Why? Because first of all, look at the distance. We start in a class 1, we should finish in a class 2. Let's take a look at the roots. As you can see, the roots of the canine is favorable to be in a lateral position. The roots of the first premolar can be even more favorable because the apex is more mesial than the crown. But when you look at 5 and probably 6, there is not so much favorable condition to be moved 5 millimeter mesial. This is the huge problem. However, since in this patient we have a coagulation disease, we were obliged to close the space because she will never place any implant, because she didn't have this possibility. First. Second, we can't use TATs for the same reason, coagulation disease. So what happened? I planned in my digital setup 5 millimeter of mesialization. Pretty hard, honestly, to achieve. Trying to keep the midline on and then recreating canine reshaping to be more similar to the lateral incisor. A large use of elastics, and look at what happened. 78 aligners. A large number, really long treatment. However, with the proper cooperation, I know I can manage this. Easy work on the right side because we are in a class 1 occlusion and we have canines, we have lateral. No, canine is erupting, so no problem. On the left side instead, I'm doing something really difficult because I'm extruding the canine. I'm trying to remove the tip of the canine and then I'm mesializing everything. And you see the overcorrection I'm trying to manage. Mesializing and doing an over-tipping to close the gap asymmetrically. So when you try to do this one with a conventional bracket system, this would be really difficult to manage. Why? Because it's an asymmetric space closure. But this is another topic. Let me show you which was my problem in this patient. I was trying to mesialize, and as you can see, first premolar was favorable and everything worked. But then when I start moving second premolar, I was obliged to do this. Let me show you more specifically. You see the situation. I need to mesialize, but I noticed that there was an excessive tipping of the tooth 2.5. So what I did, I was placing 3 mini tubes and using a 0.14 Australian stainless steel wire. Why not an eye-tie? Because at the same time, I'm closing the gap. And if you close the extraction spaces in the missing lateral space, in this case, with an eye-tie wire, you can collapse. I need more rigidity to control the space closure. For this reason, this is not an eye-tie wire. This is a 0.14 Australian wire. In the same time, the patient is using class 3 elastics because I'm closing the gap. And look at what happened. Definitely in a few appointments, I see a nice uprighting of the second premolar. And from a edge-to-edge class 2 occlusion, I see almost a full class 2 occlusion. So I'm completing my mesialization. I just need some more elastics now. Let me rescan again. With the MTA, you see here, MTA is being incorporated inside the aligners. This is pretty nice. Now in 25, I didn't finish the 78 aligners. With 25, now I can manage to start finally doing this. And that means mesializing, closing the gap, and creating the proper intracuspation. You see here, some more class 3 elastics, and finally, I can achieve my final result. You see here. How can we manage this only with aligners? Difficult, extremely difficult. We need a system that can provide to control the roots. And in this kind of situation, when we have a missing lateral, we need to control the roots. Look at this. This is the final occlusion. Of course, it's not the final restoration. We need to spend time for the final restoration with this patient. But at the moment, this is pretty nice because what we are doing is mesializing 5 millimeters. So that's pretty nice in cooperation with what we plan with the aligners. Of course, creating a more balanced smile with the proper face midline, but as you can see, still without the final restoration. What is pretty nice, I would say, in this kind of treatment is, first of all, looking at the long axis of the roots. With MTA, we were able to manage a perfect, I would say almost perfect, root parallelism in the area, in the quadrant in which mesializing 5 millimeters. The final situation at 1 year follow-up is this one, as you can see. So it's pretty nice. Full class 2 malocclusion on the left, full class 1 on the right, midline fully centered. Still, the girl decided not doing anything. But however, this is a big advantage, in my opinion, when doing this. So the root control is amazing. Of course, the root control can be something that can work, for example, even when we plan extraction. So we plan extraction, that means I have a situation in which I know that if I want to manage properly the space closure, I need to use some auxiliaries. The most common auxiliaries normally we use in aligner treatment are power arm. But of course, sometimes power arm are not really beautiful because they are visible, let's say, or at least uncomfortable. What I'm doing sometimes is this one. When I have an extraction treatment carry on, like this one, first premolar, I almost try to leave the aligner's work to close the space. And what I'm doing when I see this one, so I have this kind of excessive mesial tipping, I have no choice. How can I manage this one? I can use a power arm, for example, in combination with TATs, and this is something I normally conventionally do. But if I want to find a solution that can be less invasive than MTA and TATs, I can control this one, this uprighting of the molar with a couple of even more 3 mini tube appliance and a 0.14 nighttime wire. When I managed to do this one, what happened is that in few weeks from this kind of situation, which is really an excessive tipping, I see this nice correction after few weeks of combination work, aligners with MTA. This is beautiful, but of course, we can do even better. What we can do even better, trying to avoid to finish with an excessive tipping. Well, actually this happens, for example, when we have in mind to do a space closure of missing, or in this case, a lost second premolar. This patient has to place another implant in the lower. We want to minimize the number of implants for economical reason. So how can we manage to do this kind of treatment? Well, that's pretty always thinking in a 2 steps approach. The first one can be simply by combining aligner to, let's say, expand, align everything, change the final teeth position. And as you can see here, I don't even try to mesialize the molar because I know it's complex and I don't want to finish with an excessive tipping. This is pretty common, no? So we know, and we have all this experience. All the time we try to do this one, we can be in trouble. Why? Because we know that from the beginning, the inclination of this molar is not favorable to be moved in a more mesial position. So if I try to push mesial, what happens will be an excessive tipping. So I can do better instead of closing the gap, collapsing this space, and then using MTA. Yeah, I can do better. I can create what I published and I called G slide. The G slide is a combination of MTA with TATS in a really efficient way. I'm using two mini tube appliances, one of the first molar, one of the first premolar. I'm using a TAD between canine and first premolar, and I'm designing a sectional wire from a 0.16 stainless steel Australian wire, which is almost in a full engagement. Don't forget, 0.16 is a full engagement in a 0.18 slot. And then I'm connecting a night-eye coil spring exerting 150 grams of force. And then what I need to do? Nothing special. Sometimes, if you want, you can do some micro perforations to speed up the mesialization, which is really complex because we don't want to move the midline, but we want to mesialize 7 millimeter, 5 millimeter, the first molar in a more mesial position. What we need to do is just see the patients every month to remove the excess of the wire which is running out in a mesial direction. And then, as you can see, finally, what is super beautiful is that normally when we move mesial one molar, we see that the second molar is following. This is beautiful. We don't see a huge mesial rotation. Why? Because the 0.16 wire in a 0.18 slot is almost in a full engagement, but sometimes we can use a lingual cleat from the palatal surface of the first molar with an elastic which is going to the screw. And this can be also a way to control and minimize the mesial rotation. But look at this. This is the inclination of the roots at the beginning, mesializing with MTA, and this is the inclination of the roots at the end of the treatment. Okay, so I think this is pretty nice. Then, of course, we can close the rest of the gap with another set of aligners just to minimize the invasivity of the appliance. You see the space now is pretty close to small, so we can achieve our final space closure in a really nice way, in a really nice occlusion. That what happened. Of course, this is something that nowadays I'm doing pretty commonly, even sometimes applying some more complex mechanics, like always using MTA. For example, this is an example. You see here, I have an anti-coil spring, I have two mini tube appliances, one TAD between premolar, and an active power arm. So this is a power arm designed from a 0.16 stainless steel Australian wire, and is not only something that I'm using TADs for indirect anchorage, and I'm using the system to achieve what? Mesialization in combination with uprighting, because my system is there. Then I move in a more mesial direction and I activate both system, mesialization plus uprighting. This is pretty nice, honestly, because in this way, we can easily see how the system is doing both mesialization plus uprighting, and always manage with MTA and aligners. Root control and extrusion, two common things that can be really a problem when approaching only with aligners. So getting to conclusion, I think I've almost finished my time. Let me say this. Many years ago in 2006, I met Dr. Bob Keim, that was the editor of the Journal of Clinical Orthodontics for decades, and he was doing this one. He was just telling that probably, it was one of the editorial corner, he said that at this point we can treat everything probably with clear aligners, and I totally agree with him. But of course, we have some limitations still with aligners. So a way to overcome limitation can be really combining this system, the mini tube appliance. And following the words of another editorial of Bob Keim, we can try everything. The important thing is just trying to have care of our patients for what we are doing, trying to take some decision in the patient's best interest, and trying to document all those decisions we are doing. And I'm really in the same path of Dr. Keim, and I really appreciate from his wise words. With this, I thank you so much for your kind attention, and I hope you enjoyed, let's say, an overview on what we can do with aligners in combination with MTA. Thank you so much to everyone for your time.
Okay, thank you, Doctor. Is there anyone have a question? Yes.
Yeah. Hello. Can you hear me?
Yes, I can. Yes, please.
Okay. Yeah. May I ask any practical tips for placing the MTA, because I find the tube is quite narrow and excessive cement and quite messy. Maybe any tips on placing the tubes?
Actually, what I'm doing, it was trying to prepare a video, but unfortunately I was not able to do, just to show exactly what the way in which I'm placing. So normally what I'm doing is this one. I'm preparing the enamel, and then after I apply some bulky composites. I'm not using flowable one. I'm using the one I'm using for brackets, which is a little bit more bulky. I prepare one single really thin layer of composite, and then I put the MTA on it by using the tweezer and controlling in and out of the tube with the tweezer, just to avoid that the composite will finish inside. I cure, and then I do another really super thin layer of composite on, just to ensure that it will manage and it will stay stable, in particular when I'm using stainless steel wire. Because if you're using night tie, you can also night tie wires, probably you can simply use flowable composite. But when you're doing complex things like mesialization, like as you saw in the video, and you need a more bulky composite. So the only option is using not a flowable one, but a bulkier one. And the only thing is using the tweezer by placing to take the MTA mesial distal. The tweezer is avoiding that the composite will finish in. So it will be the only tip I can strongly suggest to you.
Thank you.
Okay.
Thấy cái nào mình thấy cảm ơn.
Anyone have other questions? Other questions? Okay, so we don't have any more questions. Thank you very much, Doctor. And thank you for taking your time to join our Osstem Orthodontics launching seminar today. So we will send you the thank you WhatsApp message tomorrow with the registration form link, that the free trial of our product. So thank you very much. Yeah, we'll conclude our launching seminar today now.
Thank you, Doctor.
Thank you to you. Enjoy your time. Bye.
Thank you.